Thank you. That's very generous. Thank you. This is Nashville, Tennessee, on a rainy day a week and a half ago. Percy Warner Park, we were just talking, is one of the largest parks in the country, but it is not as large as your Eagle Creek Park, is that it? But it's still a pretty place. This is a great place to go and capture person or patient-generated health data on your Fitbit, which we can talk about later. Mostly what I want to talk about, though, is our patient portal at Vanderbilt and our experience with it, our research with it. And I've set up this talk so that hopefully I can get done pretty quickly, not in 10 minutes, but under an hour, so we can have time to talk about it, think about new ideas, answer questions. I have no disclosures to share with you today. So when I think about a patient portal, I think about a patient portal as a piece of software, either a website or an app, that is a powerful tool for engaging patients and their caregivers, families, proxies, whatever. We have a number of different frameworks out there for what is patient engagement. In short, patient engagement is increasingly giving our patients, people, family, caregivers, whatever, access to and control over their health and health information. And I like this particular model, which came, it's a policy discussion that came out of Canada 18 years ago. The way this is set up is you have different stages or characteristics of patient engagement. All the way on the left, where you've got patients or doctors or nurses who don't want anything but the old kind of patriarchal, tell me what to do and I'll do it system, all the way to the right, where patients and caregivers and doctors and nurses each bring something to the table and are all equal as well. They're all contributing to that individual's health. So the doctor may bring knowledge and prescriptive power. The patient brings the experience of living with a disease. The patient's husband or wife or whatever brings experience caring for that person with the disease. And patient portals are the most commonly used software for supporting these kinds of patient engagement. Now, patient portals come in a couple different flavors over the years. These days, we're all kind of familiar with the classic patient portal, which is fully tethered to an EMR. You log into the portal and you see what's in the electronic medical record. You don't have really any other separate things. But over the history of patient portals, there's also been personal health records, which are completely standalone, and some of them might not even be fancy electronic applications. They're your little red book where you jot all your meds, and we still see that. But they're also electronic. Google did this for a while. Microsoft did this for a while. So there are these non-tethered personal health records that kind of fall in this continuum. Today, we're really going to talk about the patient portal, that tethered version of the personal health record. Now, we all think about patient portals as something we're required to do for what has been called meaningful use. But patient portals have been around for a very long time. By very long time, I'm using very long time in kind of informatics speak, 20 years. Really the first one, the first modern patient portal we know about was created at University of California, San Diego by Dan Mazes, who's one of the leaders in biomedical informatics. Dan and his team created something called Picasso, and Dan's great at acronyms. Picasso, Patient-Centered Access to Secure Systems Online. So this was a website that folks could log on to and access their health information, just like we do today. It was operational around 1998 after they started working on it in 96. And Picasso was used until they had to shut it down because it was not Y2K compliant and they were afraid of what might happen. You remember that, right? New York Press put in a system right around the same time called PATSYS. PATSYS was put in by another one of the leaders in our field, a fellow named Jim Cimino. PATSYS was mostly used initially as just this pilot project, though it did eventually expand. And we have this idea of an info button where you log into your portal and you see, I've got diabetes, and next to diabetes is this context-aware button I can click on and get information, educational information about diabetes. That was invented in PAPSIS. And that's since become a standard and a regulation. In Colorado, Denver, they did a project called Sparrow. Sparrow was designed to provide individuals with heart failure access to their health information online. It was used in a small randomized controlled trial where people who used it were found to be excited about it. And people who use it tend to have better adherence with their medical management. Brigham and Women's Partners, pardon me, put in one called Patient Gateway. Out of all of these, this is the only one still in use today. And by the way, like us, they went to Epic a couple of years ago, actually in the past year or so. Patient Gateway was initially designed as just one of these standard portals where you could log in and access your information. They've done some really interesting studies over the years. The one I like the best is about 10, 15 years ago, they did a number of studies where people could log in, look at their med list, and if something was wrong, tell their healthcare team in the portal that the med list was wrong and get that fixed. Almost no one does that operationally today, including them, but it was a really interesting set of studies and really a powerful patient engagement activity. So the common things that we see folks doing with patient portals, these are things you know. People can log in and access their health data. They can look up their labs, they can look up their x-ray reports. Different sites implementing portals give access to different kinds of health data on different timelines. Some places make everything available immediately, most places don't. They may make your labs available and then other labs available after a week, and some labs not available. They might not show your x-rays, or they might show your x-rays. So these tend to vary from institution to institution. Secure messaging is a key part of most modern patient portals. Secure messaging basically is the idea of, instead of picking up the phone to call my healthcare team, I'm gonna type something. And people really like this because they don't have to play phone tag, they don't have to sit on hold. They can control the message they're sending. Healthcare side likes it because it's all self-documenting. The whole conversation back and forth can go in the health record and be referred to later in a way that a phone call cannot. You can have those info buttons with personalized educational materials. Bill pay, we were talking about this morning. People actually like having bill pay. It's not this kind of, oh, you just want my money sort of an attitude. People like being able to log in and pay their bill from the same place they do everything else. Still surprises me that that's true, but anyhow. You can manage appointments, you can refill medications, and on and on and on. And I'm going to show you some other things that folks do. So at Vanderbilt, we implemented a patient portal that we called and still call My Health at Vanderbilt. My Health at Vanderbilt first rolled out around the 2003-2005 timeline. I split the difference and wrote 2004 up there. It rolled out widely through the institution in 2007. In 2013, we completely redid all the software to make it a little more modern. And this is how it looked up until November 1st, 2017. And My Health at Vanderbilt did all those things I just told you about. And it got robust use. And I want to talk about some of the use, and I want to talk about some of the studies that folks at Vanderbilt have done. Most of them are not me, so I'm telling you about our team's studies looking at My Health at Vanderbilt and how people have used it and the impact that it's had on patient engagement and patient care. I'm just going to stop real quick. Anything not clear up till now? Right. So I teach scientific communication to our students in our department at Vanderbilt. I always tell people what you're going to tell them, then tell them what you told them. So this is what I'm about to tell you. All the research that we have to date tells you these things, that our patients, our people use My Health at Vanderbilt, that they use it and receive actual clinical care through the patient portal. That usage of the portal has grown over time and spread to all the corners and specialties throughout the medical center and clinics. That our users like it, and that we can actually understand over time what technical support issues we've had, what problems we've had. And these are things that have been published or are in process of being published. So in a study one of our faculty members, Chandra Osborne, did about 5 years after our first major implementation, so published in 2011, she looked at how many people were using My Health at Vanderbilt and looked at usage logs to understand what people were doing. And in 5 years, we had gotten to 129, 800 even, thousand users in 5 years. This was before meaningful use, this was before incentives, this was just something that we were kind of doing. And I told you that we didn't really roll it out widely until 2007, so we were very proud of that. Patients used a lot of the different parts of the portal. 45% of all users at some point had sent a secure message. 50% had looked up a lab result. 30% had looked at educational materials. They scheduled appointments and paid bills. So they were using the breadth of My Health at Vanderbilt. A statistic I don't have on there is among people who used it, they actually accessed it a median 7 times per year. And I give you a median because it's not a normal distribution. It's a big spiky thing all the way to the left where some people access it every day and some people not as much. So in another study, this is a follow-up study that we are currently preparing for publication. One of our fellows, Brian Stites, has looked, and as of November 1st, this is a notable date, which I'm going to come back to. As of November 1st, we had 375,000 active accounts ever created on 400,000 patients. The reason there are fewer accounts than patients is I can have an account for me and for my wife as her proxy. So that's why you see that number. 20% of all medical center patients seen during that time period, so from around 2005 through 2017, 20% of our patients ever had used it. 61% of users were female. 78% were white. And that matches some other data that's out there in other studies. 40% had used My Health at Vanderbilt just in the past 2 years, 19% if you go back 5 years. 2% of everyone had assigned some kind of delegate. A delegate and a surrogate, those are different things. 6 had done a surrogate. Those are both types of proxies where I give my access to my medical record to someone else. A delegate is the term we use at Vanderbilt for a competent adult giving access to another competent adult. So I give access to my wife is a delegate. Surrogate is a type of proxy where a competent adult completely controls access to someone who is not an incompetent adult, maybe a child, maybe an adult without decision-making capacity, like someone who's developed advanced Alzheimer's disease. The adult child for that patient becomes the surrogate for that patient and logs on as that person, but with their own login credentials. So collectively, we had a little over 8% proxies. In a study Rob Cronin did, Rob Cronin's one of our junior faculty, he's a med peds, he's great. He did a study where he took lots of secure messages, right? And classified them manually and then classified them using different machine learning techniques, which he compared. And the idea was to try to find out what medical content was in these messages, if any at all. I mean, were patients messaging their doc and say, I heard you just went to Aruba, I hope you have a nice trip, you know? Or were they asking medical questions? Of course, we know they're generally asking medical questions, but he got data about it. He looked at 1,000 messages from a 10-year time period. They identified 721 medical needs. And they were able to classify those into different categories. And here I've got the statistics, but the long and short of it is they were able to come up with a classification scheme that you could use a human to review, or you could use a machine learning algorithm to review to determine what's in the messages. They found there are different categories. So patients might be messaging to ask about a medical problem they have. So what is COPD? They might be asking about some aspect of management. When is my colonoscopy? About an intervention they're receiving, a test they need. Is it time for me to come and get my hemoglobin A1C? And then other medical needs or communication. I need to schedule a follow-up with you. And then they still have a category for the question about the trip to Aruba, social information. And they've since used this for a number of studies. They validated this. They've done machine learning algorithms. They found that, you know, for some of these needs, certain methods, machine learning methods like random forest work better. For other needs, other methods like logistic models work better for identifying them. So this is still an area of active research for that. In another study done by one of our health policy fellows who worked with Chandra Osborne, who did that first study I showed you, they looked among diabetic patients who use the patient portal, are any of the activities they do in the portal associated with better outcomes? And what she found was that no, most of them aren't, but one is, and that is secure messaging. Diabetic patients who would send secure messages with their healthcare provider were more likely to improve their hemoglobin A1C over the course of the study. So patients are using the secure messaging to receive care, and here's at least one study that showed it improved outcomes. Now, Jamie Robinson is a surgeon who is finishing up her fellowship with us, and she did a study just published last year where she looked among surgical patients, what's the level of care that's being provided? So for those of you who aren't healthcare providers, when you see a patient and you write a note, you have to indicate in the note you write, summarizing your encounter with the patient, how complicated that encounter was. Was this just a patient with a bladder infection who's had 15 bladder infections before, and I don't have to do much thinking? Or is this a patient with some complex chest pain that doesn't appear to be a heart attack, but I'm still scared and I spend an hour thinking about it? That's called medical decision making, and it can be categorized. In fact, it's categorized when I drop a bill, I have to say what level of medical decision making it is. And so she looked at these notes to look at what medical decision making happened, and she found that there was medical decision making in the dialogue between the healthcare provider team and the patient, the proxy. 62% of the time it was fairly straightforward. But 8% of the time it was moderate. So 1 out of 12 times there was actually some complexity. Now, none of the ones she studied had high levels of complexity, but there was still some complexity. And she did a follow-up study that was just published last week, and you'll notice the publication date. It won't show up in print until 2019, so this is hot off the press for you. It's really a follow-up study on that, where she looked at the types of things that happened when medical decision-making occurred, and she found that 50% of the time a physician was the person on the healthcare team who participated in that decision-making conversation, all done through secure messaging. 30% of those, there was some management of an existing or a worsening problem. Hey doc, my incision from my hernia surgery is draining, what do I do? 25% of the time there was some adjustment of treatment, including a new prescription. And 25% there was new testing, 10% there was some kind of consultation that had to happen. The point that they make in the article, their point is, if we had done these as face-to-face visits, many of these would have generated some revenue for the health system. So Rob, coming back to Rob Cronin, who I told you about, he's that MedPeds guy who's junior faculty and a really good thinker. He looked at how the use of secure messaging grew over time. And really, this is taking that point I just made to you. Is secure messaging growing? And if so, are we doing things in secure messaging that might have taken an in-person clinic visit before? I'm going to show you a couple studies about that. So in Rob's, he showed that over the period of study, the number of patients seen in outpatient settings who did some kind of clinical messaging through the secure message system in My Health at Vanderbilt increased from year to year. And in certain specialties, it was the highest. In OB-GYN, 83% of patients use secure messaging. Dermatology, 72%. In medicine, it was 57%. So there was high penetration, and it grew over time. In another study done by Masterman, who's, yeah. It's a great question. Can they send images? We have struggled with that question for years. The short answer is no. The long answer is one we could talk about for hours. The brief reason why we don't is because there were a lot of stakeholders who wanted to think about it, make sure the policy and workflows were correct, make sure image quality was correct, and then we put it on hold for 2 years and then another year when we shifted to a different solution for all this. And this has just been raised as a possibility again. So it's a great question. It's not something we're doing now. Many of these may have been questions about meds or scheduling. So this is another study where she looked at looked again at how messaging grew, but in this case compared it to actual clinical visits that took place. So what she found, this is a busy slide and I cut it down from a much larger figure, but what you can see, look at endocrinology or gastroenterology. What you can see is that messaging grew, the dark line grew during this time, and the number of clinic visits for these patients decreased during that time. That's the light gray line on top. In some areas, it wasn't pronounced, like genetics, but in other areas, this was notable. These are people who are using secure messaging to receive care instead of coming in, they could quantify. So My Health at Vanderbilt grew, secure messaging grew. People are using it for clinical care, and people are using it for clinical care instead of coming in and being seen. And then we talk about pediatrics especially because pediatrics has these extra burdens for accessing the patient portal. An adult, if I want a portal account for me, I can just create one. I have to prove my identity, but that's it. In pediatrics, I have to prove that I'm the guardian. So I have to prove that I'm me, and I have to prove that I'm this individual's guardian. And for an adolescent, and this is all based on our interpretation of Tennessee state law, for an adolescent, I also have to get my teenager's permission to access the record. So not only do I have to show that I'm a guardian, but my 16-year-old has to say, Daddy, it's okay for you to look at my record, and the 16-year-old can take that away at any time. I also have to agree that the 16-year-old can look at her record. I have to agree that my daughter can look at her record too. I don't have to do that before adolescence in Tennessee. You might hear, I don't know. And if I'm not comfortable with my adolescent looking at her record, then I can't have access either. So the way we have it set up is 0 to 13, I have to prove I'm a guardian. 13 through 17, I have to prove I'm a guardian, and both my teenager and I have to agree to let the other access. Now, my teenager may never create an account, but in theory, I have to agree that she can. And then I can get the account. But despite those barriers, the team, this is again Brian Stites, has shown that pediatrics grew over the study period from a mere 633 accounts up to 17,000. This is still, up until November 1st, this is still a very small number of patients doing it. Since November 2nd, it's actually increased because they've gotten really charged up to do it. 16% had their own account, those are the adolescents, and 93.6 had a surrogate account. The reason it's not 100% is there was a time when an adolescent could get an account and not let their parents, or the adolescent may become emancipated by, say, becoming pregnant, and then they can get their own account without their parent having. And they do all this stuff that everyone else doesn't. So Joe Wong, who's a medical student of mine, did a rotation with me and surveyed 13,000 My Health at Vanderbilt users who agreed to be contacted for research. He got a 46% response rate, and he asked them, using a validated satisfaction instrument and user skill, computer literacy instruments, do you like My Health at Vanderbilt? And as you can see, all the respondents did, which is actually a little bit of a problem for the study, because then we couldn't discriminate what the variables that contributed to satisfaction are. So that's a limitation, but it's also a positive. And all the people out of the people who responded, they generally were computer savvy. I just learned this morning that Jamie thought it was not a high impact study, so we will be submitting this elsewhere. I don't take it personally. One of the really neat things he did was he used a sunflower plot, which is an old-fashioned style of a heat map, to look at the different factors, trying to tear apart what contributed to satisfaction. And of all of these, this is busy, but what I want you to look at is first the one in the top middle, health literacy. And this showed that the more health literate you were, the more satisfied you were. That you can see it's bright in the top right. And satisfaction with the messaging function, which I've told you is this really commonly used thing, tends to cluster in the middle of the age group. So when you look at all ages, the oldest and youngest people, that's not where messaging satisfaction is. These are people who used messaging, not are you happy with messaging. So the people who used messaging kind of in the middle were the most satisfied. And the last study I want to tell you about is I have one of our help desk personnel who decided she wanted to get a master's in informatics. And so she's getting that, actually she got it. And since she's a help desk personnel, she was really interested in what kinds of problems people are having. And she looked at a year's worth of help desk tickets that we classified, and she categorized them. Technical issues, I can't get the app installed. It's not working on my browser, which turns out to be a really old browser. That was 30%. Getting a full access request. This is something we used to do in our old system. It was a two-step process to get an account. One is you had to create the account, which didn't let you do anything, and then you had to come in and show your face and ID and prove you are who you say you are to get a full account that let you see protected health information. You could also, instead of coming in, you could call her or the help desk and have that done over Skype. Updating PHI, I logged in and it said I'm on this medicine, or I no longer live at this address, sort of thing. Educational opportunities, I don't know how to do something. My password, I don't remember my password, so getting that reset. So these are the common things that people did. And then 2% of them were calling to get access to a hard copy of their records, which they couldn't do from the So she's writing this up and we're excited. Oh, I lied, there's one more study. As we think about what we display in the portal, do we display absolutely everything that's in the medical record, or do we display just parts of it? It occurs to us that there are people who use the portal who have access to everything that's in the medical record, and those are the 28,000 employees at Vanderbilt University Medical Center. So we looked among medical center employees who have routine access to the EMR as part of their work. Did they look at their records? And if so, what did they look at? And did they log into the patient portal? And if so, what did they look at? We compared. So we had 28,000 people who fit these criteria, and among them about 10,000 had access both to the patient portal and to the EMR during the study period. Another busy slide for you. I'm going to highlight one point, just showing you that we can quantify this. What we found is that everyone generally looked at My Health at Vanderbilt instead of the EMR for results, or they looked at the portal more than they did in the EMR, but everyone still looked in the EMR. except for physicians, and physicians were more likely to look in at the EMR than the patient portal, and that's what I highlighted there for you. The other interesting data that comes from this study that I don't have a slide for right now is 100%, it's like 99.99% of those 10,000 people looked at their clinical notes in the EMR. We don't have clinical notes in the patient portal. And so every one of them looked at some progress note or H&P or something about them in the EMR. Yeah.
So that's fascinating. A question on that point. Some institutions have policies where if you as someone with access to the EMR looks at a record of someone you're not treating,
right,
including you,
right,
it'll trigger a concern and something will happen. So how does that get managed?
Right. So the question is, if you're looking up the record of someone you're not treating, it might trigger something at some systems. We don't have a good way of following that because at any time anyone could be your healthcare provider. What we do is alert you if you're logging into any Vanderbilt or Vanderbilt University Medical Center employee or student. You have to break the glass. You have to justify going into that record. However, we don't do that if you're logging into your own record. We have long had the practice and policy to support it that if you want to look at your own record, you can. The medical center actually thought about changing that, but didn't end up changing that. That was about 2 years ago, and I'm glad they didn't. So we have a good system. People use it. People receive care in it. People are happy with it, except for those doctors who looked up their stuff in the EMR. If it ain't broke, why would we change it? Why would we fix it? Well, we changed our EMR at Vanderbilt. We went live with an Epic system on November 2nd, 2017. But the patient portal was a separate application, and in theory, we could sit it on top of any EMR using web services. So we did a deep dive, and we did a comparison of features, and we found that there were differences, but not substantial enough that we would have a compelling reason to ignore Kevin's R's. Kevin is Kevin Johnson. He's our department chair. He's our CIO. He's the one who was really the head of the whole Epic Go Live. He's the one whose life and job was on the line, and he's still employed, so it went okay. Kevin, when he asked why we went with Epic, he talks about 4 R's, and I added 1. As a teaching institution where we're teaching the next generation of informaticians, of doctors, of researchers using EMR data. We're not relevant if we've got our own homegrown system and anything you learn at Vanderbilt doesn't apply to vendor-based systems out in the real world. We're not relevant. So by going to a vendor solution, we'd be more relevant. Resilience, we had a team. We have a 400-person development shop, which is a drop in the bucket. And so people were super specialized and would own one thing. My Health at Vanderbilt had maybe 5 people developing it, but if one of them took another job or got sick, that would be a major hit for us. Our EMR itself had one guy who developed it and managed it and really knew all the ins and outs. Had a big team of people work for him, but if he went somewhere else, we'd have been in deep trouble. Which brings up the replacement issue. If he went somewhere else, we also would potentially have to replace it. We wouldn't know how to do it, or replace the personnel. There's this long, steep learning curve. Replication is this idea of things we do at Vanderbilt, things we study at Vanderbilt. I can't get it published because no one's going to be able to replicate it in their Cerner system or their Epic system or Allscripts or whatnot. And then regulations, the one I added. 400 people, like I say, is a lot of people. But we could not keep up with meaningful use. We got barely eked into MU2 certification, but there's no way we, with 400 people, were going to make MU3. And by going to a vendor solution, we outsourced the whole thing. We also had a long roadmap of things we wanted to add to the patient portal that we just, with 5 people, didn't have the person power to do. We wanted to make it easier to enroll. I told you about that 2-step process. We wanted to give people the ability to log in and press a button and have an appointment or manage an appointment. We wanted people to be able to manage their own data or generate and upload their own data, and on and on and on. So we went live with Epic. So looking at the year prior to go live was November 2nd. So everything I've shown you up till now has been until November 1st at the latest. And this is the last of those. In the year prior to go live, 27% of all Vanderbilt patients had and used a My Health at Vanderbilt account. So before we did the final switch after 2 years of working and configuration, we wanted to set goals for what we should shoot for enrollment. And at this point, the highest levels of leadership were part of My Health at Vanderbilt and really interested in its success. So we talked to the folks at Epic, and they told us, well, our two best sites who've been using Epic for 5 years, one of them's at 60% and one of them's about 30%. I'm sorry, one of them's about 45%. So they said, you shouldn't shoot any higher than 30% in 6 months, 35% of the year after you've stabilized. So today we're almost a year after we went live. We're probably 6 months-ish after we stabilized. So we shouldn't be shooting more than 30%. Well, institution didn't care about that. They wanted us to go up, and I'll show you this in a minute. They want us to have 50% usage. So that's what we're working on. So we went live, and this is My Health at Vanderbilt now. For those of you who've seen my chart, it looks familiar. That satisfaction survey that my student did included my email, so 13,000 people received my email. And on November 2nd-ish, I started receiving emails. I'm going to share with you my favorite. The highlighting is mine. Dr. Rosenbloom, let me be blunt, the new system is a complete disaster. I've not been able to send a single message to any of my doctors. It's the same with a phone message. It would be nice to have a total overhaul of the system. So I'm very proud of this for 2 reasons. One is I was able to reach out to this patient person. So I was actually glad to receive the 250 emails I received that week that I didn't budget time for. Because I could reach out to these people, and because we now had signals into some of the problems we were having with our users so we could get them fixed quickly. This particular problem had nothing to do with My Health at Vanderbilt. It had to do with how the messaging system was implemented in the EMR, but it was reflected in the patient pool. So I got a lot of these, and ultimately we were able to fix a lot of problems. So here we are almost a year later, and there's a lot of things that were on our roadmap, things that we wanted to do that we now have or have started. Here's a brief list. I'm going to show you a couple of these. We've got third-party authentication. So now a patient doesn't have to come in and show their ID. They can answer those Experian questions. What was your first car's color? What is your sister's dog's name? Or whatever those questions are. If you answer enough of them correctly and can identify your birth date, name, and all that, it's going to give you an account. You can do pre-check-in. You can do online scheduling in some settings, and we're rolling that out more widely. We've got a wait list function where if you want a sooner appointment, you don't have to do anything but press a button, and if a new spot is available earlier, it will let you know. We have the ability for patients to tell us what's wrong with their medication or problem list or allergy list. We've got the theoretic ability for patients to upload their Fitbit data. We haven't turned it on yet. We've got patient-reported outcomes. We've got the infrastructure that will support telehealth, and we've got a much better billing system that we've been able to put in place. And I'm going to go over a couple of these in a little more depth. So this is just the Experian. I want to create an account. I want to prove to you who I am, who I think I am. It's currently tuned to accept about 3 out of 4 people. We don't want it to be too liberal because we might start getting the wrong people in, and they advise us 75% is about right. Kevin, my department chair, was not one of those 3 out of 4, and so I got feedback, but he understood. The patient-reported outcomes, we want to take those from a research-oriented thing. So I've got a research process. I've got a research project. I want patients on my project to answer the PHQ or the ACT or whatever before they come in. We want to take that from the research domain and roll it out house-wide for all patients. And we'll differ the questions based on what you're coming in for. And then the healthcare team can trend the results over time on patients or on their population. They can put this in their clinical note. So people are very excited about this, and people are knocking on my door because they want to go next. But we've got a 2-year timeline for rolling these out. This is the online scheduling. If I want to, instead of walking into the acute care walk-in clinic, I want to say, I'm going to be there at 10 a.m. or I want to schedule an appointment for a mammogram. We don't have this widely available yet, but those are some areas where we do. You can just open table yourself a spot. And this is the wait list idea. Up at the top, it says reschedule or cancel. If I need to cancel the appointment or find a different date or get on the wait list, I can just click on that. I don't have to talk to anyone. This is an iPhone. Apple, so this is Apple's doing. This is not our doing. So don't, if you're an Android user, it's not my fault. This is Apple's doing. Apple now allows, if you have an iPhone 11.4 iOS or higher, you to connect your patient portal, if it's an Epic patient portal and your institution has decided to play. Peter and I have talked long about that. He's thinking about it. He wants to. You can connect your patient portal to your iPhone, and it uses a Smart on Fire service, or Fire service, and puts the data straight, if you authenticate it, straight on your phone. It doesn't go through some Apple server. So I have all my health data on my phone. So if I wanted to access it, I don't even have to log into the portal app. Why would I do that? Well, the reason I would do that is because now a third-party app developer can come along and access, if I give them permission, the Fire encoded data that's now stored on my phone and create an app to help me manage my high blood pressure or diabetes. And what's nice is because it uses this Apple Health Hub, if I'm also counting my steps, which don't go in my patient portal, or if I'm recording my diet in this or that nutrition app, that will also be available to the app developer to put in whatever app they create to help me manage my diabetes. So we're very excited about that. The medical center works against pillar goals. Every fiscal year they create new goals. And right in here is use of My Health at Vanderbilt. There's a lot of things in scope around My Health at Vanderbilt, but the idea is we want to make, like proms, use of the patient portal a standard part of how you receive care at Vanderbilt. You check your blood test today, you can log in to see the results in a week. We'll call you as well if we need to. Don't call us, use secure messaging, stuff like that. And we want to increase enrollment up to the 50%-ish. We want to do that, again, so we can make it a standard part of the care processes we give. We want to do that because, again, this is our top patient engagement application, and patient engagement has been shown to be associated with improved outcomes. And then this also sets us up for doing things like telehealth and increased online check-in, proms, and we think it's going to improve satisfaction among our patients and employees. So this is a busy spreadsheet that shows the busy work we did to define the pillar goals. What it shows is if we're looking at current proportions, pediatrics versus adults, to get to that 50% reach goal, 60-something% of adults have to do it, and that would bring up peds, since peds is a little lower. However, peds has gone from like 10%. Some of their clinics are already up to 30%, so they're taking this very seriously. They don't want that assist from the adult. So as of right now, we're about 42%, which gets us over our very lowest threshold goal, but not to that top goal that we're shooting for. And this varies day to day, and I watch it more than I watch my retirement account. We've got a team of people. It's not just me. We've got a team of different people who think about patient engagement in our institution, people who work with patient family advisory groups. We've got executive leadership. We've got a large team of people. This isn't, again, just me on a bully pulpit talking to people and telling them to use it. And then we also have operational leadership and PEDS leadership. We're planning to promote it to employees. We want 100% of employees to use it so that they can be champions and so that they can answer questions about the portal. And we're going to start by enrolling new employees. Right now, we're at about 50% of our employees using it. And then we're going to have a big enrollment promotion push over the later fall and winter to try to get this rolling. This is what one of the sets of posters looks like that will go throughout the clinics. A lot of people are contributing to these efforts, to the research efforts, the operational efforts, to the development work, to some of the different apps that we spin off on this, and then to the interface and marketing work. I have tried to make sure everyone involved is on this slide. I always apologize in case I missed someone. It was not intentional. And so with that quick buzz through, this is also Percy Warner Park, I'm happy to take discussion or questions. Thank you.
I'm sure there's a lot of questions, but I do have another one for you to begin. So one of the things that Vanderbilt certainly has been a leader in is really being leading in terms of getting people to participate in research activity, and there was an opt-out approach for a while. Now there's an opt-in, I understand, and the like. How do you envision, if you could just say a little more about how you envision My Health at Vanderbilt being part of that solution to engage people in their research?
So the question is, how do we envision My Health at Vanderbilt being part of our research enterprise? There's a few pieces to that puzzle. It's a great question. One piece is we periodically message all of My Health at Vanderbilt users who have not previously answered this question and ask them the question, can we contact you directly for research studies without going through your doctor? That 13,000 people we surveyed comes out of a larger pool of people who said yes and do it via email or My Health at Vanderbilt. So that's one part of it. Right before we went live, we had a way where you could toggle between My Health at Vanderbilt and My Research at Vanderbilt, which is a tool developed by the REDCap team that allows you to manage all your research projects you're part of or may want to be part of. And it's linked up with things like Research Match, which is a patient finding application that matches researchers looking for subjects and individuals who want to participate in research or maybe need to participate in research because they've got a certain disease with investigators. And so it would link up with all that. We haven't brought that back live yet, but that's on our roadmap to bring back live. And then third, our portal users are generating additional data that feeds into our research data warehouses that we can use to do interesting studies. So those are our three main pieces of that puzzle. Thank you. Other questions?
Yeah, so this was, I was curious, have you set up any guidelines or practices for providers in responding to these messages? Because this was something that in my previous institution, when they tried this, it quickly got very Wild West and caused some angst.
So the question is, do we have guidelines in place around handling messages? The written guideline is that all messages should be handled. There's guidelines for patients and providers, I'm sorry. The guideline for patient is do not use this for anything acute because people may not see it right away. And it even gives them other ways to get help if they need immediate help. And that's actually part of the patient's user agreement. If they abuse that, they can lose access. On the provider side, the guideline is the message needs to be handled within 2 business days. And if it doesn't, it typically gets bounced back to the patient or escalated in some way. And in the old system, we used to generate reports on messages that we would send to managers, clinic managers, for messages that were getting too old. There was a little bit of a disconnect. I think it was a 7-day, if they'd sat there for 7 days. We don't have that set up in the current system yet. That's something we probably will have set up at some point in the current system. But right now, messages can still go there and die. But it's uncommon these days for that to happen. So those are the main guidelines in place. In terms of what to handle in a message, we really leave that up to the provider's discretion. People have generally embraced this. And again, that may be the culture of us having done this for 15 years. We ask them to think about it the same way they would if the patient made a phone call to ask medical clinical advice. You know, what's your limit for what you'll do over the phone versus bringing them in? and use that same sort of personal or clinic by clinic guidance when you're handling secure messaging.
So you showed us some reactions of patients when you switched to MyChart. What in general was the delta between the homegrown portal functions and the MyChart? What was better, what was worse, what did clinicians like, and so on?
So what was the delta between the old and the new? So a big one was the user interface. There's only so much we could do to control the user interface. Everything we had done before had tried to keep our user interface consistent with everything else we do that is Vanderbilt branded. And now we couldn't do that. We could only like move icons around. We could shift, use different graphics for the icons and change the color palette. So that's one major change. There are a couple subtle little workflow things that became more difficult. So people now couldn't find the after visit summary. There were other things that are both a plus and a minus. So the way in our old system we handled pathology results was we handled them as a report, like an X-ray report, but of its own type. The way Epic handles them is that they're a lab result. And so suddenly, and this surprised us, breast biopsies were showing up in the patient portal the day after they were reported. And so people on the beach were suddenly reading their breast biopsy report, and we got feedback. And so we had to adjust our policy since we couldn't fix the computer, but we were able to shift that to 14-day delay, which is what we consider our longest delay. There's nothing that no lab result that we withhold, with one exception, beyond 14 days. That one exception is Huntington's disease, because there are national guidelines that Huntington's disease results for this universally fatal disease, and people who have Huntington's disease tend to be a little bit irrational with decision making as the disease starts to onset. So that there's a well-known phenomenon of people with Huntington's disease finding out the result and killing themselves. And so the national guidelines are that there's a counseling session involved with giving the result. And so until we can control who's ordering that testing to make sure the counseling's done, we're not putting those in My Health at Vanderbilt. As soon as we have those controlled only to the Huntington disease providers, we'll put those at 14 days. But that was one of the things that was surprising to us and we had to fix. On the other side, the delta is we got immediate online scheduling. We got immediate waitlist scheduling, though it took us 6 months to turn it on. We got immediate Fitbit or other device integration, and we haven't turned it on yet. We got this Apple thing that we're excited about. And a few of those other features I've shown you. We got the proms, the pre-check-in, all of those things. So those are things we'd always wanted to do and would eventually have gotten to. But this way they just came for free.
So thank you for a great talk. I had a question about potential disparities. I saw you described about 78% of the population was Caucasian. I'm not sure how that compares to the medical center. And I know there's some literature a little dated, but from Group Health's portal, where they saw some disparities in access to their portal. In fact, I've done a recent systematic review with the VA fellow here, his name's Will Tarver, that was published in JMIR to look at differences in patient-centered technology use among vulnerable populations. And there's not a lot in the literature. So, I mean, some people would say, well, maybe we shouldn't deliver care through these technologies, but I mean, we are practicing in the 21st century. On the other hand, using these technologies, we don't want to contribute or exacerbate disparities. And so what are some of your thoughts about that?
That's a great question. I'm glad you asked. The question is just the general question about patient-engaging technologies and disparities. And I would say disparities in healthcare and disparities in technology use. If I may. We have the data that I've shown you. Brian Stites is doing a deep, deep dive looking at the characteristics of users versus non-users to try to get at this question, looking over 500,000 users and 15 years of usage. And the idea is he'll correlate what you do, if you do anything in the portal, with who you are, your demographics, what your health conditions are. And I'm hoping he'll put in geocoded information so we can kind of understand where you live and what that's like. the limited data out there and the non-empirically studied data that I look at every day when I look at these reports all supports the idea that there are substantial disparities, and that rich, white, educated women who are middle-aged or a little older use the portal more than anyone else. We think, but we have no data to support it, and we're looking at it, we're hoping to look at this, that putting these applications on smartphones will help close some of that gap. A lot of the reason for disparity has to do with things like language and mobility and computer literacy, but a lot of it just has to do with access to computers. And generally speaking, we understand that disparate populations can access the internet more readily on a smartphone than they can on another device. And since certain health conditions are more common in those disparate populations, there's more incentive to use the portal. One of the things we also know non-empirically, and we're working on fixing that, is that people with chronic diseases use the patient portal much more than people who are healthy. Our inflammatory bowel disease clinic is at 90%, for example, adoption. I've told you house-wide we're 42. They're at 90%. So people with syndromes like that are going to be more incented. And since some of these chronic diseases are more common in these disparate populations, we think, but need to study, this is our hypothesis that we need to test, that the smartphones are going to help bridge some of that. And then making this just a standard part of our operating model will also help with some of that. Interestingly, pediatric asthma, which is the third clinic we're going to go to with our proms, at the time we first looked, this is a serious chronic disease for which patient engagement has a strong role. They're about 2% adoption. Since they've increased, and they're about 10 to 20%, because like I said, PEDS is taking this very seriously. But it shows that not every chronic disease and not every disparate population chronic disease is easily going to come in the fold, if you will. So, and we're always open to new ideas about how to solve this. Other questions? I'm happy to chat. My email is obscured by the leaves, but I'm also happy to hear from you by email if you have ideas or questions or other thoughts, or want to tell me what I said wrong. I'm happy to hear from you. So, thank you.